Hello, my name is Professor Ingrid Scheffer. I'm at the University of Melbourne and Austin and Royal Children's Hospitals in Melbourne, Australia. I was fortunate to be invited to speak at the recent Syngap One conference at the American Epilepsy Society in Orlando, in Florida. And they've asked me to re-record my talk due to some technical difficulties. My topic is new insights into the developmental and epileptic encephalopathies, with an emphasis, of course, on Syngap 1. And here are my disclosures. So in this talk, I'm going to go through 4 major areas. I'm going to start by defining what we mean by the term developmental and epileptic encephalopathies. I'm then going to turn to some very recent data we have on the epidemiology of different developmental and epileptic encephalopathies, or DEEs. I'm going to talk about a study we published this year examining the rates of convulsive and non-convulsive status epilepticus and the mortality rates and SUDEP rates in different genetic developmental and epileptic encephalopathies. And then the final section is on a talk which is just coming out now in the journal Neurology on movement disorders in patients with genetic DEEs. So let's start by defining what do we mean by this complicated term, developmental and epileptic encephalopathies. Well, here we're putting together 3 different concepts: the etiology or cause, whether the child has developmental slowing or regression, developmental abnormality, and whether they have epileptiform activity on their EEG, or epileptic activity. And we'll start with the concept of just epileptic encephalopathy. And here the idea is that you have this very frequent epileptic activity which causes impairment of development. And really the prototypic form of this epileptic encephalopathy is infantile epileptic spasm syndrome. There you see a little spasm in a little Indian girl I care for who's an identical twin, and both twins developed this, and you can see a spasm there, this little series of very subtle seizures. And these infantile epileptic spasm syndrome are associated with a very abnormal EEG called hypsarrhythmia. And the baby typically shows developmental regression with loss of skills. So that's what an epileptic encephalopathy is. And then we expanded this term to developmental and epileptic encephalopathy. The reason for this was that we realized many causes, and in particular, when we think of causes, you think of genes, cause developmental abnormalities or impairment in their own right. And as well as that, they cause this epileptic encephalopathy, which actually further affects development. So one of the prototypic forms of this, of course, is Dravet syndrome, which is due to an abnormality of a sodium channel. And here you see the alpha-1 subunit of a sodium channel, which forms the pore or the gateway into the cell through this channel, through which the sodium ions pass. And this is the cell membrane in which the sodium channel sits. And in Dravet syndrome, which is due to mutations or pathogenic variants in SCN1A, you get this cause causing developmental slowing, and then later on the child develops very frequent epileptic activity and has further developmental slowing and goes backwards. And this is an example of what the gene abnormality is doing, not the epileptic activity. A little girl here of 6 with normal gait, and a man here of about 28 with very abnormal crouch gait with dystonia due to SCN1A. So it's the developmental encephalopathy as distinct from the epileptic encephalopathy. So just to conclude this definition section, when we talk about developmental and epileptic encephalopathy, we're talking about the child who has developmental impairment, then gets this superimposed epileptic encephalopathy. And here you see a little girl with Syngap 1 having a very nasty myoclonic atonic seizure. But the problem is that the more we understand about a specific gene, and Syngap 1's a good example of that, the more we see a spectrum of presentations, of which we call a phenotypic spectrum. And so when I see a child or an adult, it's important to try and understand their cause, so their gene name, SYNGAP1 developmental and epileptic encephalopathy, as well as their syndrome, because they both reflect or both impact on my treatment choices. So now let me share some interesting data about the epidemiology of DEs. And there's been a lot of debate about how common they actually are. And together with my New Zealand collaborators this year, we actually published the cumulative incidence to 16 years of all DEs and found that 169 per 100,000 children have a DE. And this point is very useful. 1 in 591 children will have a DEE. And this is important for government to ensure we get adequate resources and enough multi-skilled workforce to care for these children who are so sick. So while epidemiology may not seem that relevant to a family with a child, it is relevant in terms of helping the community to care for children with these diseases. Now, when we talk about the developmental epileptic and epileptic encephalopathies, we're actually talking about a whole range of different epilepsy syndromes. And these syndromes are more common ones, such as infantile epileptic spasm syndrome, Lennox-Gastaut syndrome, Dravet, epilepsy with myoclonic atonic seizures, much rarer ones, including a whole group of very severe ones that begin by 3 months of age. But there are also many individuals with developmental and epileptic encephalopathies who may not fit into one of these neat syndromic boxes, but still clearly have a DEE. So it's a very important concept to understand. And with our epidemiology, well, actually, just before I get to that slide, with SYNGAP1, these are the main developmental and epileptic encephalopathy syndromic boxes that we see. Epilepsy with myoclonic atonic seizures, and that's like the little girl I just showed you who had that very dramatic drop attack. Epilepsy with eyelid myoclonias, as we have very rapid eyelid fluttering and you're often photosensitive, and Lennox-Gastaut syndrome, which is characterized by nasty tonic seizures, which can also cause you to fall to the ground. Now, in this recent epidemiological study, we looked at the frequency of many of these syndromes, and you can see infantile epileptic spasm syndrome occurs in 58 per 100,000 children, whereas epilepsy with myoclonic atonic seizures, which is present in SYNGAP1 or common presentation, is 16. So it's sort of the second most common out of these syndromes that we see. So now I'd like to move on to the first of two studies, and this one examines the rates of status epilepticus. Now this is defined as 30 minutes, and we look at both convulsive and non-convulsive status epilepticus, the mortality rates, and SUDEP, which stands for sudden unexpected death in epilepsy, in people with different genetic developmental and epileptic encephalopathies. And this work was led by a very talented pediatric registrar called Alice Donnan. So in this study, we decided to only take cohorts or groups of patients where we had at least 10 individuals with that particular gene, and we study both children and adults. So the study involved 510 patients, and you can see all the different genes involved in the study. SYNGAP1 was the second most common after SCN1A, which was mostly Dravet children and adults, 203, but there's also SCN1A non-Dravet. And SYNGAP1 included 60 individuals with SYNGAP1. And what we found was the median age at study of the cohort was 10 years, but notably almost 80% was still under 18 years, so the age that we define as childhood and adolescence. And the range, though, was as broad as 1 month of age to 79 years of age. We found that the median onset of convulsive status epilepticus, where the child seizes for 30 minutes, was 8 months. This is partly skewed by the fact we have so many Dravet children in the study. But what was very interesting for me was that the non-convulsive status epilepticus began at a median age of 5 years. And this is where you spend 30 minutes not being very aware. You might dribble, you might be unsteady, you might be just not with it. And that's called non-convulsive status epilepticus. And when you do the EEG of the child or an adult, you find constant epileptic activity. So starting with the different forms of status epilepticus in different genetic DEEs, well, you can see that Dravet syndrome, 90% have convulsive status epilepticus, which we would guess, and about a quarter have non-convulsive status epilepticus. Here are the other genes which have more convulsive status than non-convulsive status epilepticus. And here are the whole group that we studied. And notably, SYNGAP1 is seen here, and nobody had convulsive status epilepticus, which is wonderful news for SYNGAP1 children and adults, because convulsive status epilepticus is definitely life-threatening. But it doesn't mean it's impossible. It just means it's not frequent because it didn't occur in our 60 patients, so it's a reasonable size. But we did have some with non-convulsive status epilepticus. Turning now to the death, we found that 8% of our cohort had died by the time we performed the study, and the median age of death was 7 years, and you can see here the age at which different individuals died. And in blue here you see those who died due to sudden unexpected death in epilepsy, which was accounted for almost half the deaths, and the median age of SUDEP was aged 10 years. And you can see that some of the deaths occurred due to convulsive status epilepticus, and again, in some of those individuals then developed cerebral edema and died. And their causes of death were others such as drowning, withdrawal of care, respiratory infection in 6, which we know is always a bigger risk in this type of disorder. So what about the genes? Well, the biggest issue, most important gene in this mortality rate was SCN1A, and it accounted for 16 out of 20 SUDEP deaths in individuals. For 12 of the 20 SCN1A deaths were due to Dravet syndrome, which accounted for 6% of the cohort. When we looked at those with the non-Dravet DEE, so the early infantile, the mortality rate was much higher, over quarter of the patients had died. So what about the genes associated with SUDEP? Well, SCN1A, SCN2A, we had 2 individuals, SCN8A, we had 1, and we had 1 with STXBP1. Now, unfortunately, I can't tell you this means that children with SYNGAP1 won't die, because they could die. I have had an adult die with a respiratory infection, but it just means that their risk of SUDEP is fortunately not high compared to the other genetic DEEs. So in this study, we found that different genes put you at risk of different complications, such as convulsive status epilepticus, non-convulsive status epilepticus, and sudden unexpected death in epilepsy. And I don't think this is, tells you definite facts for everyone, but it certainly gives us some leads about when we should worry about what particular complications. So understanding these risks informs clinical care. It helps doctors to manage and counsel parents about these risks and what to look out for. And it certainly has worked for me many times that my Angelman syndrome parents of a child with Angelman syndrome will be much quicker to recognise when that child has non-convulsive status epilepticus and present to the emergency department so we can diagnose them and give treatment. And the earlier you give treatment, the more likely that's going to prevent the child having developmental regression. So very important to recognise them. People often recognise convulsive status epilepticus because it's frightening, but non-convulsive status epilepticus can be slow to recognise. All right, now the final talk the final discussion I wanted to have was around a paper that's just coming out now about defining movement disorders in patients with different genetic developmental and epileptic encephalopathies. And this work was led by a very talented medical student at the time from the Netherlands called Sterre van der Veen. She's now training to be an adult neurologist, and Gabby Say is also an adult neurologist. So what happened here was that I realized in clinic every day that a lot of my patients with genetic DEEs had movement disorders, and we've been spending so much time worrying about the seizures, we hadn't really looked at this in detail. And you can say, well, why does it matter? Well, we need to distinguish epileptic from non-epileptic movements because they have different management. They may need medication, and if it's seizures, obviously anti-seizure medication, but if it's a movement disorder, they might need movement disorder medications. And there are also other strategies we can employ, such as deep brain stimulation. So in this study, we hypothesized that specific genetic developmental and epileptic encephalopathies are associated with specific types of movement disorders. And then that the patterns of the movement disorders reflect the underlying neurobiology of the disease. This study began by me and my collaborators, who were both pediatric epileptologists, and we worked with pediatric and adult movement disorders in Italy and in Australia. And we identified patients who had a known genetic DE, so we knew which gene was involved, and we saw them in clinic or the ward, and we saw that they had a movement disorder. And then we characterised the age of onset of the movement disorder, the course of the patient, their epilepsy syndrome, their severity of intellectual disability. We used videos to classify the type of movement disorder, and then we classified them as hypokinetic, which meant stereotypies, dystonia, chorea, myoclonus, and tremor, hypokinetic or ataxic, and then went on to analyse the patterns of movement disorders with different genetic diseases. Now, this is really a pilot study to get some understanding of this, because it's a very complex field and we need more patients. But we started with a healthy 77 patients who at the age of study had a median age of 9 years, but were aged from 1 to 38 years, and 3 had sadly passed away. The median age of onset of movement disorder was 18 months, which is interesting because the median onset of seizures was actually 4 months. So we had a very severe group of patients here with seizures early, mostly in life. And here you see the seizure types: epileptic spasms, myoclonus and tonic-clonic seizures. The subgroups of developmental and epileptic encephalopathies, with over half having early infantile, which means it begins by 3 months, about 30 having infantile, and only 10 having later onset. And here you see the epilepsy syndrome in our cohort, with 8 having Lennox-Gastaut syndrome, 4 infantile epileptic spasm syndrome, 5 Dravet, 4 epilepsy of infancy with migrating focal seizures, 3 epilepsy with myoclonic atonic seizures, and 1 with the progressive myoclonus epilepsy. It's also very important to recognise that this group of patients, these 77, were severe, with severe intellectual disability in 72%, and a further 15% had profound impairment, and 70% did not walk. So what do we find? Well, we found the most common movement disorder was stereotypies, followed by dystonia, chorea, myoclonus, ataxia, tremor, hypokinesia, and other. And dystonia was more common in non-ambulatory patients and more common with moderate to profound intellectual impairment. And ataxia was more common in ambulatory patients, which is partly because we can diagnose it then, and those with mild intellectual disability. So here you can see the genes that were involved, and there were 1 or 2 with Syngap1, but mostly other genes were involved. So here you see the most common movement disorder, which is stereotypies, which began at a mean of 21 months and occurred in more than half the patients. And here you can see 3 individuals with potassium channel KCNQ2, DEE, and the little guy that you can see is having some stereotypic rocking and arm and leg movements, as has the next little guy. And then this big girl is a bit higher functioning, and she has this backward stereotypy that almost causes her to fall over. The second type of movement disorder is dystonia, with a mean onset of 14 months. And here you see the same boy at 2 different ages with dystonic movements of his legs and arms. And you can see he really doesn't find it very comfortable in the image on the left. And this began at 6 months to 13 years in different individuals. The next group is chorea, and this occurred in 11 with choreoathetosis and 7 with bulismus. These 3 boys all have the early infantile profound DEE due to SCN1A, and you can see this very prominent chorea as well as mouthing movements that are part of the chorea that you see. And here you see another disease, Dynaman-1 DEE, and here you can see a brother and sister, 2 with a similar sister at different ages here. And you can see that they have this very sort of little movements, which are called chorea, which had a mean onset in our cohort of 12 months, but couldn't begin from 4 months to 13 years. And you can see just how severe it is in the brother when he gets a bit bigger. In fact, it's so severe they cannot take him on an aeroplane to visit me for a consultation. So what about the biology? Well, we could begin to make some correlations, but as I mentioned earlier, we need much better data to be able to do this well. The channelopathies, sodium and potassium channelopathies, and synaptic vesicle trafficking genes were most likely to be associated with dystonia, seen in the light green. Transcriptional defects were most likely to be seen in the purple, associated with stereotypies, and then other different mechanisms were associated with mixed pictures, and these include post-translational defects, transporters, and signaling disorders, and this is where Syngap sits down here. So in conclusion for this study, we found that movement disorders are under-recognized in patients with genetic, developmental, and epileptic encephalopathies. Differentiation, the movement disorder from a seizure can be challenging, and sometimes you need video EEG monitoring to distinguish whether it's a movement disorder or a seizure. But more often, the smartphone is our tool here. So I ask families to do me 3 examples of each movement disorder, and that way I can look at the context in which it occurs. What's the child doing? Are there any triggers? And how stereotyped it is, which means how much does it look the same every time? We found some correlation with specific genetic, developmental, and epileptic encephalopathies, but we need larger cohorts. And my dream, and I think will be reality, is that one day our treatment will be tailored to the genetic etiology. So in concluding this talk, understanding what a developmental and epileptic encephalopathy is critical, so that patients can be diagnosed with these diseases. The cause can be found, and we now have 825 genes that lead to DEEs, and then treatment can be targeted to the genetic disease, which today might just mean choosing the right anti-seizure medicine, but in the near future, hopefully, will mean gene therapy. The epidemiology of DEEs has found 1 in 591 children have a DEE, and this will guide investment, policy work, and drug development. We can now find the genetic cause in 50% of patients with developmental and epileptic encephalopathies. But these different genetic diseases differ with regard to their risks of status epilepticus, mortality, sudden unexpected death in epilepsy rates. And so understanding the gene informs your management and counselling for families. And movement disorders in patients with DEEs need to be differentiated and may require treatment in their own right. I'd like to close by thanking the fabulous team that I work with in Australia, also my many international collaborators, and most importantly, of course, patients and their families. Thank you very much for listening.